be looking at the uterus and some of the other reproductive organs and the pelvis and how these appear on radiographs of the pelvis. And then we'll also then move into some additional pathologies that'll help hopefully reinforce the normal anatomy of the pelvis. So in this patient, you'll notice that they have had a bilateral tubal ligation. So you can see the clips here that have been placed around the uterine tube or the fallopian tube to prevent future pregnancies. And you also should be able to note here that there's an abnormality located right there in close proximity to the bladder, which is going to be located sort of in this region right here. And so that is most likely going to be a ureteral calculus, so a kidney stone lodged in the right ureter. Here's an example of uterosalpinography. So this is where a dye is injected into the cervix, which will then make its way up through the uterus, into the fallopian tubes, and ultimately it'll be extravasated into the abdominal cavity. And that's totally normal. That's what we want to have happen. We want this to be out here. You can see it kind of free floating in the uterus. That's totally normal. That is indicative of, that's a very good sign for reproductive purposes. So this is what you want to see in a fertile female. Whereas down below here, you can see this is an abnormal hysterosalpinograph. And so in this case, what happened was the dye was injected. You can see it in the uterus, but then now you can see how the dye has not been able to exit the fallopian tubes like you would expect. And so as a result, that almost always indicates that this person is not going to be able to get pregnant as a result of that. And so there's a number of different things that can be done to help remedy that. But this is just a common study that's done early on if a female presents complaining of infertility. So now we're going to look at a series of images watching a hysterosalpinograph being completed. So you'll note that you'll be able to follow the dye into the cervix, into the uterus, and then ultimately into the uterine tubes. So here you can see the speculum that's been placed into the vaginal canal, and then this is going to be the tube that's going to be injecting the dye. So you can see just a little bit of dye here at the tip of it, and so you should be able to appreciate this. And then you'll see where the dyes are exiting the fallopian tubes. That's going to be called the ostia or the opening of the uterine tubes. So here we can now see the dye making its way through the cervix into the uterus, and then now you can see the dye extravasating out of the fallopian tubes and freely into the abdominal cavity. So again, if you kind of follow these back and forth, you can just watch the dye as it's being extravasated. So again, that's a sign of a normal hysterosalpinograph. This is another common, or not, I shouldn't say common, but relatively common issue that can come up with women of reproductive age, which is an ovarian teratoma. So this is sort of like you'll get numerous germ layers that are forming, and so the reason that it looks kind of hyper intense in this case is this is a molar calcification. So it sort of looks like a tooth almost, and so that's why you get this type of appearance on a radiographic image. So we've seen this image before in the course, but just to review real quick, so you can see this is a PEG tube coming across to the stomach to provide tube feeding for the patient. You can also see down here that there's an external fixation device that's been placed in the left femur, and then so that's obviously indicative of a femoral fracture. And then in the midline here in the pelvis, you note that there's a relatively large bladder stone in this patient. So bladder stones are quite common in folks who are bedbound. So especially patients in nursing homes, again, oftentimes you'll see these large bladder stones that form in these patients. It's pretty rare for folks who are mobile and able to get around without much issue to develop bladder stones. It certainly can happen, but it is relatively rare. So in this patient, you see a good example of a highly distended bladder. So the bladder does have a significant ability to distend, including all the way up into the abdominal cavity, but this is just a relatively extreme example where you can see this, what you might think is an abnormal or like a tumor in this patient, but indeed this is just the bladder highly distended in this individual. Then we have a couple of examples here of various types of cystitis. So cystitis describes inflammation of the bladder wall. So in the upper image here, you can see where the dark outline that you're seeing in and around the bladder wall, that is a collection of air in and around the bladder wall. So that's just one type of cystitis. And then down here, you can see that there's this sort of hyperintensity around the periphery of the bladder, so really within the bladder wall. And so that calcification, this is a common issue that arises with schistosomiasis. This is an example of benign prostatic hypertrophy, so BPH, and you'll notice that the P here represents the prostate. So the prostatic urethra, of course, would be deep within that location, right in the midline. And so as a result of the enlargement of the prostate, you can see how it's pushing up the base of the bladder and kind of forming this slight concavity there at the base that's highlighted by those black arrows. And so, in some cases with prostate cancer, one of the ways that we treat it is with radioactive seeds. And so this is brachytherapy is what it's called. And so there's a bunch of these little tiny radioactive seeds that are placed in and around the prostate to try to kill the tumor. And so this is something that obviously shows up kind of as sort of this odd appearance on a pelvic x-ray. So you want to be aware of what you're looking at. If you see a bunch of these little tiny seed-looking things along in a male pelvis, that's going to be indicative of this brachytherapy in that patient. It's also a significant risk for us anatomists when we're accepting bodies. We have to make sure that the patient has not, or the donor has not had the implant of these seeds. So that has happened at a number of medical schools across the country, where the students are dissecting, they get into the prostate, and they start finding all these little tiny BB-looking things in the prostate. It's actually extremely dangerous because they are still radioactive. They don't stop being radioactive. The half-life of these is quite long, so you do have to be very careful. You should take standard precautions as you would with any sort of radioactive substance with these pellets. So this is obviously a abdominal pelvic X-ray, so a radiographic conventional X-ray, and so there is a slight pathology here, and so you should be able to note that right up here. There is a small renal calculus right there. And then looking at the same patient in cross-sectional view on CT, you can better appreciate the location of that calculus within the kidney. And then here's another example of another renal calculus down at the UVJ, so right at the ureterovesical junction, so the junction between the ureter and the bladder. And so this just again reinforces the location of that junction where it's posterolateral along the bladder wall. And one thing to note with that is about 90% of stones that are less than 4 millimeters are almost certain to pass through the ureter directly into the bladder without any need for external intervention. So here we have another pelvic X-ray, and so if you do your typical survey, you're looking at the obturator foramina, you're looking at the pelvic brim. You might miss in this case a very subtle fracture that's located right here along the acetabulum. So again, this is a fracture of the acetabulum. So if we zoom in on that, you can maybe appreciate it a little bit better here. But where you can see it really well is here on the CT scan. So this is a coronal view, and so now you can see this is a patient that fell off their horse, and they were complaining of hip pain several days after falling off their horse, and so they had this subtle acetabular fracture in this case. Here's another example of a significant abnormality. So in this case, if you follow the Shenton line, you'll notice that it's not that nice, smooth, continuous line like you would normally expect. You can see how the head of the femur and the neck of the femur sort of drop down from the normal, what you'd expect to be the normal position. So this person's experienced a fracture of the femoral neck. And then this is a radiograph of a normal sacrum. So you can obviously make out the anterior and posterior sacral foramina, where the anterior and posterior rami of the S1 through 4 sacral nerves are going to be emerging from the sacrum. And then you can also obviously make out the SI or sacroiliac joints on this patient as well. This is a lateral view of the normal sacrum and coccyx. So again, you can see the normal concave appearance of the sacrum. You can also make out the sacral canal, which is going to be the distal continuation of the spinal canal, and then eventually that's going to end at the sacral hiatus, which is going to be where then hopefully you recall your S5 spinal nerve, and then also the first costal spinal nerve are going to emerge before they ultimately travel out to their sites of innervation. All right, so here we have another pelvic scan. And on this one, again, you can see where it can be easy to miss things on a pelvic scan. So I mean, if you kind of do your normal survey of the bony structures and you look at the pelvic viscera as well, you don't notice anything abnormal in this patient unless you look up along the iliac crest. You don't want to forget to also look at the ilium when you're looking at a pelvic scan. And so in this case, you can see up here that there's a slight abnormality along the pelvic or the iliac crest. And so this is called an apophysis, which is effectively a normal bony outgrowth that arises from a separate ossification center, and then it fuses with the bone in the course of time. And so these can become problematic. In some cases, they're prone to avulsion fractures. That you can also develop inflammation of it, which is apophysitis. And so that can obviously cause some issues for a patient. And so this is one way to be able to diagnose that condition. So in this case, you can see that there's a slight abnormality with on the patient's left side. The pubic symphysis doesn't quite look normal, and so we'll look at a more extreme example here. You can notice that there's this inflammatory process that's affecting the pubic symphysis, in this case bilaterally, though worse on the left than on the right. And so this is an example of what's called osteitis pubis, and so that's characterized by non-infectious inflammation of the pubic symphysis, which just causes pain for most individuals. And here we see in this patient, there's also an example of a hyperintensity down here. So I want you to think about for a moment whether you think this would be a ureteral stone or something else. So if you look at it closely, so this is a zoomed in view of it, you'll hopefully note that the center part of it is hypointense. So that indicates that this is not a kidney stone, not a ureteral calculus, but instead it's a phlebolith in this case. This is an example of the vermiform appendix. So obviously this is usually found in the false pelvis. So where you can see the vermiform appendix. So just keep that in mind, that is a structure that oftentimes you'll see in the false pelvis. Here this is kind of a review of what we've gone over previously in the abdominal cavity. So obviously in this patient you can see that they have a hip replacement. In this case, so this is not an external fixation device, but you can see the acetabular cup that's been placed. You can see the screws that are keeping that in place. And then this is the replacement head and neck of the femur. And so that's stuck right into the femur bone in this patient. So that's a hip replacement. And then you can see the plica circularis very clearly in this patient. So you're looking at lots of small intestine as well appreciated in this patient. And now in this one, hopefully you can make out the large intestine quite well. So you can see the haustra or the saculations, and then down here you can also note where there's a large bowel obstruction, so you get this dilation or distension of the large intestine, and then it disappears distal to that location. So again, this is an example of a large bowel obstruction. And then here, remember that when you get free air in the abdomen in an upright, or in this case in a supine individual, that's usually going to make its way up over the liver or the stomach. And so in this case, you can see that free air right below the right hemidiaphragm, just above the liver. So that's an indication of free air in the abdomen. And then here we are looking at a cross-sectional view of the abdominal cavity. So we're below the thoracic region, so hopefully you can kind of get a sense of where we're at. These two structures right here and right here are actually the kidneys, and hopefully you'll notice that they do not have a typical appearance. And so this is an example of polycystic kidneys, and so here's a gross view of polycystic kidneys. So you can see that you just get all these cysts that form on the kidneys, and so that gives them this very odd appearance on imaging. Here we have another pelvic scan. And so this patient was brought in by police officers because they were suspicious about them potentially carrying drugs in their body cavity. And so we can hopefully make out these two body packs that they've put in there. So we've seen an example of that before, but this is another example of body packing.